Bueno, yo voy a presentar una ponencia
I am going to present a paper that is coordinated, taking into consideration the 5 questions that were asked in the guidance for the debate that we received. And before that, and at the end, I will speak about some conclusions regarding the debate and the discussion that will follow. I would like to make 4 remarks that will guide to a great extent the presentation I will be making. Firstly, we have to avoid a methodological temptation of finding liaisons, close liaisons among the 2 topics that we are addressing. Obviously, conditional money transfers have an incidence on health, but we will have to avoid having a model or arriving to conclusion that in view of the complexity of the phenomena that have to do with the attention in health may seem too optimistic or quick. And secondly, and this is related to, we also have to avoid the temptation of thinking that money transfers, to the extent that they determine the attention of health, when in fact we all know the Lalonde model that says that health systems only explain less than 30% of the health of people, and 80% is explained by their attitudes, the environment, and also conditioned transfer have an incidence on this, and perhaps we may find better explanations than simply saying, I'm giving you the money and go to the hospital. I will come back to these. The third is that some 15 years ago, in our countries, the idea started that social development has overcome sectorial barriers of the old structure of sectorialist ministries, health, housing, education, work. In this regard, we have the ministries of social development, although there are other forms. For example, in Costa Rica, the coordinator ministry in Ecuador, the old Chilean media plan. Let me say, the only way of resolving the articulation of sectoriality is not by creating ministries. It is generally the most common, but not necessarily the best. And finally, the last component, they have to consider that in these developments, a lot has to do with the liaisons and the links of political economy among the questions raised. Personal liaisons, how to territorialize problems. There is something that has to do with the manner in which things are done. I will be providing some examples about this. The first question that was raised was how to sustain social policies in times of global crisis. The first thing that we say is, what is a social policy, we may ask? Because this has created a lot of confusion. There is a residualist vision. The market resolves everything, and social policies only have to assist those sectors of the populations to which the market cannot help. We have the labor visions or labor views. There is no best policies than employment. This is absurd. Labor policy is one thing that provides for employment and income. But social policy is not based on income. I will come back to this later. If it is based only on income, we don't need social policy. As any public policy, there are actions from the state, and they have a purpose, which is to generate equality of conditions. Purpose, try to avoid the term or the expression equal opportunities. This is something out of our way. When there is equality of conditions, there is equality of opportunities, equality of condition, access to social services universally and not as a residue. Which are the conditions that a social policy has? How can we define in an integrated manner a social policy? In the paper that we have prepared in the Council of Health and the Social Council, we were working hard on this topic. There are 5 conditions defining the nature of social policy.
We can access to health services in 2 ways, with a price or through a tax. You access paying through a price that has to do with the cost of production of services. In the case of health, this is a private insurance policies. I have a premium because I'm old and I live in actually with lead, etc. And also they make a policy for me, make an analysis of my risk, and I'm charged a prime, and I pay for this prime or premium. This is a mechanism of access on price. The other things, I can put the money, yes, basically the US model, and some other models also, from other countries. I mean, the other option is that I pay actually a common fund. This common fund, I put money according to my income. This fund pays the health providers according if I'm old or if I'm young. It's just as other systems. It actually has a premium. It's a risk premium also because of age, because of sex, whatever. What is the difference? That in the first model, the premium of the risk is paid by the individual. In the second model, the premium is paid by the common fund. So I'm young and wealthy, I pay a lot and get very little. If I'm poor and old, I pay little and I get a lot. Actually, I'm just putting it actually in exaggerated form. So this, in the documents that we have designed, we put it in the sentence also is according to the income and according to the needs. The second point is the universal character. This is one of the key points of this whole meeting. The universal nature means that a policy is designed for the ensemble of the population. It doesn't mean that what is granted in the social services, be it health or be it education or be it housing, will be equal for all. There's a certain confusion stating that the universal policies are a type of single design in which everybody is included and get the same and access equally too. So the one thing is focused policies, and another thing are focused actions in the universal system. Let's say education system should be universal. In essence, definitely there might be programs, specific programs that can be actually with grants or with scholarships or different types of learning processes for certain segments of the population and not for others. It would make no sense that a young person will have a scholarship to study if he has money. But it makes sense for somebody who without to have, so is actually someone who doesn't have money should be granted actually a scholarship. And this is also the fact that the system actually has a universal design. There's a universal design, but should be adapted to the different heterogeneous conditions of the population. I'm going to go back on this point because I think that one of the big problems of access to health of the excluded sector that's through transfer actually should be entered is that the health systems do not know how to work with this type of population. I will come back to this issue later. The third point actually is the state. Actually, it comes from the previous points. Let's imagine a private health services that would charge people according to the age and sex. So let's imagine this private institution of health. They have an affiliation of all young people. They have low per capita. They would actually go bankrupt. It's clear that the only thing they can do make this transfer between actually providing by variables according to the needs are basically always age and sex, because it's the parameters we have used, and the probability does better reflect the relationship between the health needs and also funds. And this can only be done by the states. The other thing is the social participation, community participation, popular participation in actually inner countries. Also, they have different names. Uruguay laws talk about social participation. Also, it refers to the participation by the community. This can have different formats in some countries. In the case of Uruguay, we have different systems and health and education. In others, you have the participation also as community-based level. In others, you have the participation actually of other authorities, the different modalities of participation. And finally, also is the budget. And as far as the systems of social security, EU systems of health, of social policies are deficitary, so we're just financed with the personal contributions of people that do participate. Actually, a rate should be very high, should have actually a contributive and non-contributive model that have to do. So, actually, this is what we said, that this is clear cut to see that there has to be actually a type of modeling. Then the response to social policies in times of crisis have a political component, meaning, well, when I saw the situation, actually, there can be a crisis situation. So we see it's a critical situation, and then you have to adjust budgetary items. Also, there are different options to be found, and the option ends up being political in essence. What I said here, let's say a list, is the experience of several of our countries, the experience that Ecuador and Venezuela had when the oil price went down. The decision that was made by them was exactly actually providing the social services and also matched it with other budgets. What happened in Uruguay when they had the first recession, a decision made by the Argentina, also where they had also to face an economic adjustment period, was actually to be able to protect social expenditures. In this case, this is another discussion, which is the fact that social expenditures do have an adaptation factor, which is very important too. It can be a percentage of GDP, or, for example, in the case of Uruguay, actually part of the budget, for example, in the case of Argentina, or be it a minimum, a certain minimum, there can be different modalities, and this somehow actually protects social expenditures somehow, and collection can be based on other types of branches of variables, and in fact, empiric evidence shows that this has been done so, at least in these 4 examples that I have provided you with. They have studied Ecuador, Venezuela, Uruguay, and Argentina. I don't know so much the case of Brazil, where they actually, or what I don't watch has been the evolution of some of the also like the programs which is called Bolsa Familia, which is a cash transfer program so stated by this administration. Well, the second question is almost the typical question to be asked, the ones that we pose ourselves all the times. Condition transfer, cash transfer, actually have to do with the fact that being compensatory policies, and what are the conditionalities. In terms of conditionalities, actually something like, how can I put it, that is part and parcel of the war in social policies. It started as from our karma. Our karma is our destiny, is our daily problem all the time. We are saying no, people. We have to give and have something in return. Also, get to fall into paternalistic models. This is something we have discussed. Why is it that we are giving money for those who spend it actually in alcohol? Also, in all countries, we must hear this every single day, all the time, and this is a permanent debate. And to be able to discuss this further, I propose myself to think this from a different viewpoint. Also talking about a different methodological viewpoint, not to talk about the conditionalities, yes or no, but we have to discuss the historic context for conditionalities. We have to see within this context they're proper or not. And this is why I split the analysis in 3 moments. The moment where the cash transfers emerge, they emerge as a program, as a mass program. Basically, it's after the big crisis, the neoliberalism generated in countries in the 90s, because cash transfers have existed forever. In Uruguay, for instance, 1943. In Argentina, started in 1950-something. Also, these are cash transfers too. So the cash transfers, but he had yet another. Yes, they gained another vision and momentum as of the actual increase in poverty in our countries, in almost all countries of UNASUR, but also all countries from Central America, Mexico. There have been some transfers that are conditioned. Even some countries are not conditioned. So I try to show 3 moments when they emerge to give a response to this impact on poverty, the moment where they are to be consolidated as transferred in order to support social integration, and basically a type of long-term momentum where from the viewpoint, let's say, of the critical situations, this could not be so necessary, quote-unquote. I will discuss these points further later on in my presentation. Also, this shows this first slide. Actually, they're influenced by the need of overcoming extreme poverty, and they're clearly compensatory. So the first stage, they are compensatory response to basic needs. It's money. Also, the different modalities are the countries that give money. Other countries that give actually magnetic cards to buy food. In other words, they give out actually magnetic cards that you can spend at your will. This has been already overcome, but all the analysis, the studies, also talk about serious evaluations made on expenditures, show that 90% of expenditures of people in extreme poverty that were given cash transfers should spend the money wisely in food, actually in hygiene products, and 10% also might spend it actually unwisely. But we see that especially in there, also we see that actually people say that they actually drink it, but it's not true. But they're very marginal. Studies made actually also about the transfers and the Solidarity card in the Dominican Republic, the different cards actually of the Bolsa Familia in Brazil. All the studies show basically that In general, this money is well spent. This money is well spent, associated to reasons. One is in general, because all the holders, which are women, and the second, hunger. You have a card, and this is well focused. In general, our countries have had experiences of every single type of the poor focus, but corrected in time. Fortunately, they're well focused. People very swiftly use them wisely in order to buy food. So the discussions on how to give it is kind of exceeded. In my case, I support the idea that we have to use cards for purchasing food products, for example, and allows also, of course, we can say that it seems that depends on the moment when this is done. So clearly, there's of compensatory effects, and the conditionality is not relevant. Here, because we could wonder. Let's imagine it doesn't comply. Actually, in extreme poverty, households want to resolve an immediate urgent problem. What would be the conditionality? What is the measure of conditionality? Actually, take away the cash transfer, things get worse. In this first step, conditionality is not relevant. Of course, also here we see the difference between focused policies and focused actions. Also, it is relevant for policies. The only thing will be done with this person is somehow, as is the only thing that's going to be done is good. And as a result of all of this, also we are able to integrate these people to other circuits, education and health, that are conditionalities are more widely used. They have jobs for participated in a program to get a job. But basically, the best node are health and education. And as for this is a transit, a path towards integration, towards yet other policies, that at midterm, the conditionality as such actually excludes and does not include. This whole discussion also, I believe, which is very important for us, those of us who are in social policies, and we have this political economy of social policies, because I do understand that someone who sees this out from the outside, let's imagine from the economic policy point of view, actually believe that it has to be a compensation. And so it's a middle class mindset of this type of rationale of the effort, of culture, of work, also that are concepts that are alienating, but it's a different topic. So I do understand this is legitimate. This is why it's legitimate that this debate should be open. It is very important for me to hold the tools that provide evidence. For example, what people spend the money in, even though they have no conditioned expenses in the terms of, for example, of transfers for a child as a family allocation or as a family grant. Then this evolves in times, the cash transfers as a part of a bigger system of social protection, and not only an action. Actually, to put out a fire, start to evolve in time and start to be diversified. It's not just anymore the payment of a certain amount of money to a family in extreme poverty or in moderate poverty. There are some cash transfers that are for extreme poverty, but in other countries, in Dominicana, for example, that you put it into moderate poverty. Let's try to incorporate other variables, like, for example, put here in the slide a plus per number of children. We have here the family grants, also protected work, programs of scholarships to have an ongoing education. When we analyze not extreme immediate poverty, the one that derives from the impact of the crisis, but the one that stays when the crisis is overcome, these three problems, the continuity of education of teenagers, the more qualified insertion in the job market, and the health of children and adolescents, appear as the most important problems that define the continuity and permanence of structural poverty. So we see problems that do supplement the cash transfers, giving a plus per child, providing a scholarship so that the teenagers can stay in school, and then the conditionality acquires a greater importance because the transfer programs are already connected to different social integration mechanisms that are not just meant for food. It would be kind of obvious if there's a scholarship for schools, the child has to stay in school. Otherwise, the same thing goes for health. It's unprotected, where the person has to participate in the jobs and be trained and also take part in courses. This is kind of obvious, but more than a conditionality, it appears a co-responsibility of the person in the social integration process. These are the two basic stages. I put a third stage, very simply, not wanting to go into the debate on this topic. We're talking about the long run, but I think the ideas of cash transfers that emerged in the 90s as of the crisis periods, it's an embryo of what, let's say, we had worked on in social policies of a basic universal income, actually the right of the citizens. So we said that in the first year, the year 2000, again momentum, and then actually got its breath. But in the long run, I think that the countries do need to generate social protection, monetary, cash, universal transfer. They should be independent from the conditions of the people. And obviously, the conditionality is the citizen. The condition is the citizen, is to be a citizen. He has also a lot of fundamentals aspects, but also is not the object I just mentioned, in order to complete the time cycle on how I see transfers. It's a triangle. They start as a compensation, that they turn into social integration mechanisms, and they could end up in being actually universal income or basic income. The second question, also aligned with what you have been saying, I think that the questions were very well set. I'll go from the general point of view to the particular point of view. They were very well thought of in order to respond to the purpose of this presentation. Questions to their contradiction within the universality of health as right and the focus actually introduced by the cash transfers. I explained this before. I understand that the 90s obviously were contradictory in essence, because the focus was on a purpose in itself and didn't generate any transit towards universal services. But in the year 2000, as of the of economic, social, and political changes of most of our countries, social policies do generate a path towards the universal system. Those are tools that are a route towards a universal system of social policies. For example, what is the sense of a scholarship? During the 90s, actually, vis-a-vis the crisis to the educational system, the only strategy at play was actually being trained. We cannot generate economic and social conditions in order to do this purpose. But definitely, let's take a course, lots of painting, of culinary arts. That's just not to talk about industries. So we have a new, so the person can acquire new skills in terms of requalification. But the object was just to leave a few conditions so that actually they can work in the formal market. Also, but it was a concept is not by chance that during the 90s, in a period of strong deregulation of social policies and strong residuality of social policies, actual labor also training courses, requalification courses have appeared. We have different institutes that were dedicated to training for better jobs with their compensatory policies within the market, in the job and labor market. The same thing can happen also with health policies, education, and so forth. The next question and the last question before talking about assessments says, how do you link the concepts of equality and equity in the health services in relationship with the conditioned cash transfer policies? Then the question would be, well, within a framework of focused policies or focused actions that tend towards social integration and towards universal policies, we have to look at where are these inequalities, this inequality in conditions, also lack of conditions of opportunities, so as to know where do we act. Then there are the inequalities, let's call them a class, traditional related inequalities, mostly because of inequalities in jobs and earnings. This is very new territoriality also that came from the segregation, territorial segregation of the 90s. And before that, it wasn't hard, but it was not so simple to map poverty, because, well, there were neighborhoods where the rich people live, but there were social mixture. Residential segregation, in my opinion, was a clear-cut strategy. Is not people in the periphery pay less. The strategy of actually deliberately concentrating residentially the people of lower income, and generated today that we can do the mapping of poverty, and we might find areas where majority the population that lives there are poor.
An advantage for social policies, because we have micro territories, we have but with small territories in the provinces or departments, and therefore we see the inequalities, territorial inequalities, and there are other inequalities that need policies, gender, ethnic, race. In general, inequalities are, there are gender inequalities, but people that are in the higher areas of society do not have the same problems as the poorer one. There is an emphasis in the situation regarding economics which is applied to other inequalities. It is not the same, the problems for finding a job of the young people for a young person whose parents are up in the scale than those who are below. The youth and women in total have problems. It means to say also that inequalities are self-feeding situations, because they self-feed themselves. How are action in health related to focal actions on transfer? There is the first link. In order to avoid concentrating all the liaison, all the links on health is conditioned. And these insights in how to improve health, the improvement in income has a direct incidence. The people with better income, they They see the reality from another viewpoint, and they have better conditions to look for a new job and to have health services, and also better conditions so that their children may continue studying at school and avoid leaving school and going to work. But clearly, there is an incidence in the attention of health, because if they look for a new job, they have to have their health certificate, and this is an obligation of the formal labor market, and perhaps in many places in this area of the population they go to the informal sector, but in general they have incidence on health attentions. People that are at a higher level, the more the improvements in the economy are accompanied by other situations. For example, having better buildings, better houses, because the quality of life improves, and also the attention in healthcare. However, obviously, it is necessary to have some actions in this health system so that these conditions take place, especially strengthening the budget at the first level of healthcare. In general, what happens when we visit the neighborhoods and these poverty situations, extreme poverty situations, we don't have problems of hospitalization or surgery. We find people that are not immunized, that they don't have their vaccines updated, and their problems are resolved through the immediate response of the clinic to these situations, and that our health systems, even with the efforts and the health reforms in the UNASUR countries, they continue to be, I don't want to give you numbers, but basically it's hospital services, and continues to be a privilege for some of them. I don't know in the rest of the UNASUR, but in Uruguay, a physician working in a territorial polyclinic receives less money, probably because it's more risky to work in a specific area. But this is not demonstrated, but they get more money. There is a natural ordering of the health system towards the lack of primary health care, although we have all the discourses of all the models. The first is to strengthen the budget, as I said, and the second one is to, if I put the person into the health system, I have to have mechanisms to have a real attention. This is a formal mechanism in the health registries. For example, in the area of education, it's the same. We don't speak about the quality of the service. In many of our countries, for example, the laser program in the Argentine, assistential goals in Uruguay, they have incorporated in their health processes what we call assistential goals, integrating the system of health remuneration. Obviously, whenever we have a relationship with private service provider or with a professional who's working in the system of captation or assistential goals. An additional pay for some of the issues, control of children, pregnancy, and so on. Finally, the last question is which assessment actions do we have? And there are very little. In most of our countries, they know their national reports, domestic reports. We have in the case of Uruguay, we have the social emergency national place. The results in terms of health are very weak. And precisely, line in line with my previous words, in the case of family pay, which has a broader spectrum, we are speaking that while social emergency covered 110,000 houses, the family pay reaches 240,000. Many families are covered in this way. The same, the universal pay per child has better results, but it is not very clear how they exchange other public policies in the area of health that promoted the other programs, for example, the NACER program. And also the condition transfer in the area of health in low-income populations, Brazil, Colombia, Honduras, Malawi, Mexico, and Nicaragua, in which the conclusions are also of very light impacts and difficulties for measuring impact, because to measure the impact we have to have here in our mind the cruces, the exchanging between one and the other, and the systematized version of the work doesn't have very strict conclusions or clear conclusions. Taking all this into consideration, I have some conclusions in order to promote debate. It is clear that the policy of money transfer, conditioned and used in our countries to act in poverty sectors, they created the use of health services, which are used anyway. There was an effect in this case. How much it was related to collateral policies, directly or not, but in fact there was an effect. But this takes us to those products of conditionality. And in addition to the time difference, short, mid, and long term, I would like to add something social aspect. With countries with low development and with almost no development of social rights, because there are new rights and there is a search of those, but high coverage countries in which high poverty is a result of income crisis and not structural crisis, as we call them, conditionality is absolutely marginalized, and if it doesn't exist, it wouldn't have had very different changes in the access. The third conclusion related to the previous one regards to the promotion of the health system, generated not by the transfer of funds only, but also by the programs that are being added as a second circle related to employment, which demands certain attention in the area of health, all the liaison of adolescents to the educational system that demands healthcare services. The fourth conclusion has to do with the control problem, because seen from another angle, I'm speaking about the inspection that seeks to see the situation so that conditionality is applied and enforced, suspending transfer and all that. We see the need to control in order to enforce the rights, because in general, extreme poverty sectors, they have a culture. There is no culture of rights. I was mentioning to Alexander during breakfast that when we visit some programs, there is a feeling of gratitude and not a feeling of having a right. And this feeling is dangerous, because they say, if for some reason, budgetary change of policies, the right is suspended, well, they gave it to me, now they take it again, it's finished. I had it some time. That means to say they don't exercise the right to have it enforced. It is necessary to generate a control in the sense of transforming the culture of thinking and make it a culture of rights. In that sense, we need to work a lot, and for that reason, and obviously professionals in the health area or the educational area, those professionals have their own tasks of curing, educating, preventing, promoting. We need social teams in these areas, and that is why the integrality that we were mentioning before. To this point, these four conclusions are related to how the people that receive money transfers demand health services. To see the view of the demand. However, we have to see the offer, the supply of the services. The attention in the area of health, and this is also valid for education, of excluded populations require knowledge, some type of activities, how to address problems that many times health professionalization doesn't have and repeals from the bureaucracy that creates admission mechanisms in hospitals, that for somebody who is which is normal, and some people are feeling out of the system. A social worker follows, accompanies a person on a health center, and they lose 90% of the time, because if they leave and they keep it working, he won't stay. So the supply of health services, not only in terms of budget, in order to have a response, because this is the increase of the population serviced. Because when, in our statistics in Uruguay, we always had a universal coverage, because there is a constitutional norm that says that everybody that has money can pay, and if they don't have resources, the state will pay. Yes, I am this private insurance, or I go to the public service. Now, this is formal accessibility. Real accessibility is far from that. And this implies a great growth, both in health and in education. Uruguay has an educational public because of the increase of populations, and it is an increase almost quantitative and qualitative because there are many people that have no health services that require different actions in order to solve the problem. The health system doesn't offer proper services. Bad quality services, that means to say that the professionals are good or bad, no, or whatever. But in that regard, they don't have an impact on health, and sometimes the services are non-existent. The seventh conclusion is that notwithstanding all this, or in the framework of this, money transfers more in context of more poverty or recent impacts of the crisis may be effective to increase services, health services. But in order to do it not as a focal action in the midterm, they require better services and the work on accumulated poverty and strengthening attention in territories that need it. They require more integration of the value chain because this health system creates some values, and there is a change from the first level until the specialized services with the presence of the public policies for promotion and prevention in health. Transit, alcohol, and so on. We know that these are public policies, and that although the population referring money transfers in general is not, the response is not immediate, when the attention services become universal, they start to improve. Well, this is what I wanted to tell you, this conclusion that try to be less strict. I have a critical vision, but I understand that the conditionalities in certain social and historical contexts may be helpful for the interaction process between social and health policies.